Well, Peter, thank you very much for this honor and the pleasure. And I'm deeply touched and surprised about the last photo, but I cannot imagine how you got this photo. It is from South Tyrol in a very special restaurant. And it's one of my most favorite wine stubs in South Tyrol. It cannot be other explanation that you contacted my wife. So thank you very much for this honor. It is a pleasure and an honor again to stay here and to speak to you and to share this excellent meeting, which is unique in the international setting. And you continue since long of time, and I'm one of the first you invited to this meeting, though I share this meeting over nearly 10 years. And I'm very proud to be a member of your complication staff. So, ladies and gentlemen, usually it is a boring topic, hygiene in endoscopy. But the problem hygiene in endoscopy and the proper reprocessing has become one of the most interesting topics of our time, and it can be more dangerous than all complications you talked about here this morning. There was a recent article in the New York Times in this August, and they discussed the duodenoscopes contaminated with multi-resistant germs who have sickened hundreds of patients in hospital outbreaks. And at the last of the article, they discussed the use of disposable duodenoscopes for the futures and to discuss to be redesigned all the instruments we have to guarantee a proper access to the patient. So what is the background of this? There was a long-lasting and still ongoing series of multi-resistant microorganisms in endoscopy, and they all were related to ERCP and ERCP-related methods. All started in Chicago with a series of carbapenem-resistant Escherichia coli. But then there were other series published, like in Berlin, in the Charité, in Seattle, and others not in scientific journals, but in public journals. And finally, the very interesting story from Rotterdam with 30 patients attached by Pseudomonas aeruginosa. Though the reason for the problem and the source was found in the distal end of the duodenoscopes. Here, in this part, in and around the Alberon elevator, there were places to harbor superbugs and to give rise to contamination and further on to infections. This former version of a duodenoscope had a removable cap, and in a good intention, the end cap was redesigned to a fixed distal part, making easier the access for the endoscopists, but more difficult for reprocessing and to clean. So in and around the Alberon elevator, there was the source of our problem. All these series had 4 common points. Only lateral viewing endoscopes for ERCP were concerned. There were multi-drug resistant bacteria belonging to the group 4. And that means they were carbapenem resistant, and they were resistant so against all antibiotics. And in the protocols of reprocessing, there were found no breaches with the complete handling. But what was new? Micro damages in the distal part in and around the Albaran elevator were found. So the problem was not only the bacteria, but only a mechanical. And most serious were published in the States. So what about multi-resistant bacteria? They are registered in a special system, and we talk about MDN4, not of 3. Usually we have 4 great antibiotic groups: penicillins, cephalosporins, carbapenems, and fluoroquinolones. And usually, if all the other fail, the carbapeneme group is still working. But in these cases, although carbapenems didn't work, so the bacteria were active to inactivate all the beta-lactamases and carbapenemnases which they brought with, and the patient had no further alternative for therapy. Unfortunately, there is a series from the Netherlands, which was published 1 year before in Gut. In this nationwide study, the Center of Rotterdam controlled 745 site samples in 67 centers. So all the ERCP active centers were included in this trial. And they all handled following the same protocol of reprocessing given by the Institute of Hygiene and Microbiology in Rotterdam, under the supervision of Margaret de Vos. The results were 39 centers were contaminated, and in 50% duodenoscopes were found with multi-resistant germs, and they included all the spectrum of the distal gut. And the conclusion of this trial was the present reprocessing and process control procedures may not be adequate and safe. So what was the answer of the American societies to this article in the New York Times? In fact, they highlighted that ERCP is a life-saving procedure, and more than 700 patients are treated every year in the US. And elimination of the risk of infection transmission is of top priority. But they have to admit that the post-marketing study, which was initiated by the FDA, revealed that testing of duodenoscopes following reprocessing were in 5% positive for bacteria. So obviously our system does not work completely and very well. And the discussion was further outlined to disposable duodenoscopes, but there was a common view that they cannot be adopted today without understanding new and unintentional risk. That means they have to be checked before they can be brought to the market. And the 4 societies, they pronounced that new technologies for reprocessing are just in the pipeline, and we improve the design. So we again changed our duodenoscope, and we replaced the fixed end by removable end caps. And there is now a recommendation that before ERCP, the physician and the treating endoscopist has to discuss the risks and benefits of ERCP to the patient. So contamination does not mean exactly infection. But what is the real number of infected patients? Unfortunately, we do not provide so many data. And this is one study from Los Angeles, which is very interesting concerning how many patients are in fact contaminated and colonized. Though this history started in October 2014, and the problem was detected in February 2015. And in a retrospective analysis, the number of patients with available cultural data which were exposed to the duodenoscopes had the number 104. And within them, only 15 patients acquired the specific germ, and only 8, so around 6%, had an active infection. But 7 were colonized, and this demonstrates the other problem, because the colonized patients without any clinical symptoms, they can transmit the multi-resistant bacteria to other people in the hospital and in the community. So hygiene in endoscopy, be responsible, be alert. So ladies and gentlemen, this is not a state-of-the-art lecture. It cannot be, because things are changing a lot within a few months. So this is just an interim report to give you an overview what is going on now in reprocessing and in the infection discussion. So coming back to the basis, flexible endoscopes and its components are regarded as semi-critical devices. Semi-critical tools have only a high-level disinfection as a reprocessing process. So they must not be sterilized, because in tubular organs, normal flexible endoscopes do not open vessels or lead to mucosal breaks. In contrast, every endoscopic accessory like polypectomy snares, like biopsy forceps who open up vessels, they are regarded as critical. And so they have to undergo a validated, standardized, sterilized process, or they have to be used as disposables. Disinfection is defined as the reduction of the number of viable organisms on a device by irreversible destruction to a level appropriate to safe use on a patient. Well, this includes nearly all microbial pathogenous bacteria, but not necessarily all spores. And in contrast, sterilization means complete destruction of all microorganisms, including bacterial spores. And they have to undergo a validated process, which is defined by the Euronorm 11.13.7. Usually, the method used is steam autoclaving, but this is not possible for endoscopes, because this was damaged completely, our instruments. So what can be offered as a sterilizing process could be a low temperature sterilizing agent like ethylene oxide gas, but we will see this pose other problems too. So reprocessing of endoscopes is a very delicate multi-step procedure, and it has 3 general parts. A manual part from the start with bedside cleaning and Soraf cleaning by brushes, including the function and the leakage test. The second part in the endoscopic washer disinfector with rinsing, disinfection, neutralization, final rinsing, and in the new version, drying. And again, a manual part with transportation and storage without the risk of recontamination. It has to be remembered that the usual bioburden after a normal colonoscopy, for example, is 5 to 10 log steps. But the elimination rate by this whole multi-step procedure is only 8 to 12. So the safety margin with 0 to 2 log steps is very short. And it comes clear if any part of this procedure fails, the result would be terrible. And we have the complex design of flexible endoscopes. With these small, narrow lumina where we don't have a regular look in, and the complexity, in addition, of the distal mechanism. So 2 years ago on the DDW, an American group presented for the first time an insight in the small lumina with a prototype video camera. And independent of a new or old instrument, they found debris, stain discoloration, scratches, channel shredding, moisture, everything. So the internal part of these channels is not even. In contrast, it gives rise to harboring germs in the scratches and crevices. And this is a case with the problem of biofilm. Biofilm means that bacterial plaques can surround it by organic material and by mucopolysaccharides. The mucopolysaccharides will contain a fixed covering around the bacteria, and they may be resistant to every part of reprocessing, in particular to brushes. So the problem of biofilm, which can only exist by the presence of liquid, is one of the main problems in reprocessing. Though the endoscope has to be completely dry at the end, and all the small protein plaques, bacterial and blood formations after the endoscopy have to be removed by extensive cleaning. So simeticone is coming into question. Simeticone is a clearing substance we often use for destroy the bubbles in the stomach or in the colon. But simeticone has, depending on concentration, a liquid retention effect. And this was proven by an increased ATP bioluminescence test, despite a correct reprocessing. So simeticone is no further recommended by the manufacturers, because by adherence to liquid in the small channels, this can give rise to the biofilms. In this trial, an American group tested what is better in drying, an automatic process or the manual drying by our nurses. And they could show that the manual drying over 10 minutes is less effective compared to the automatic procedure. And they tested how many liquid droplets are in the inner channels. And in fact, by the manual process, by manual drying, there were more, and this may also be a source of biofilm formation. So there are two weak points in our reprocessing procedure, and they are both related to the human factor. The cleaning and first step with extensive brushing, with cleaning at once in the endoscopy room, with elimination of microorganisms, which leads in fact to 4 locksteps bacterial elimination. And that contains all the gut bacteria and the multi-resistant drug organisms. And finally, the drying and storage part, with recontamination in wet areas and biofilm formation, and that is the role of Pseudomonas aeruginosa. The FDA has recommended in a letter healthcare facilities and manufacturers to begin transitioning to disposable components of the distal part of the endoscopes to reduce risks of patient infection. And in their post-market study, they looked also what is going on with the personnel. Do they follow all the instructions, the revised protocols of the manufacturers? And in fact, they found that users had difficulties to understand and follow manufacturers' reprocessing instructions, with a fatal outcome of reprocessing. In fact, there are some details to ameliorate, to use a different kind of brushes to proper clean the distal part of an endoscope, independently if it is fixed or is it a removable cap. And all the manufacturers have now changed the end cap. All offer a special removable end cap which is disposable and which allowed a better access to the distal duodenoscope end. And in the middle part of the reprocessing, there is also a new construction offered, the pass-through washer disinfector, which separates more clearly the clean and unclean area within a wall and avoids contamination from one to the other side. So there were a lot of attempts to ameliorate the process. Double high-level disinfection, so nothing else but do the process twice, reduces but does not eliminate positive bacterial cultures from duodenoscopes. The result was better, but it was not zero. Ethylene oxide gas sterilization, you remember low temperature sterilization for 16 hours, long time, reduces but does not totally eliminate the bacteria. And even in the Chicago clinic, they found a new multi-resistant bacterium even after ethylene oxide gas sterilization. And it damaged considerably endoscopes. So this this way of reprocessing has not been regarded as an optimal one. But in contrast, further and repeated microbiological hygienic tests, they identified the critical parts and they reduced the contamination risk. So what is about sterilization and the topic how to handle? Now, steam sterilization, how it can be used for accessories, is really not possible for flexible dermolobile endoscopes. Low temperature sterilization with the common substances is not effective enough. And we are waiting for something new in the pipeline, and more there are offered some substances who are little promising. And disposable scopes, well, this is a long discussion, but can you imagine a duodenoscope with an optical performance of our daily routine with the same maneuverability to a very fine economic price? I don't think this is really possible at the moment. And don't talk about the trash, which is a result of such a procedure. So I think this is not realistic at the moment and only for special situations like in cholangioscopy and pancreaticoscopy. So what is the European view of that problem at the moment? The European societies, they focus more on the personnel, on the staff, and on the microbiological checks. And there is an ESGENA curriculum published this year which describes in detail the quality and competency and the necessary training of the reprocessing staff. And the message is clear: intensify the competence of your staff and have regular hygienic tests to check the quality of reprocessing and to identify your weak points. This is an interesting chart from the Seattle clinic. They also were concerned in a very difficult way. The Seattle group, they checked the endoscope in a very short time in a microbiological continuous testing. Now you see here in the long line from February 2014 to December 2016 a number of microbiological examinations. And you see in the balls, the gray, the white, and the dark black ball, the difficult instruments. In fact, by testing, they found that even the same endoscopes were concerned. And obviously, there are endoscopes who are not regularly to reprocess. So, in detecting this problem, they removed the first one, and the number of positive tests went down, and they removed the second one, and finally they removed the third one. And then the number of positive cultures is going down and nearly to zero. Well, this is a very good message and a very good result which underlines our European strategy. So, what are the possible future ways out of the dilemma we have? Because we are still in an ongoing process to make our procedures perfect. There's no doubt that we have around 5% positive cultures. But avoiding this, there must be a low-temperature sterilization method which has a perfect cleaning effect, not to the distal end alone, but also to the small channels which pose the other problem. And I think robotics maybe one day replace human handling in the whole process with cleaning, disinfection, drying, transportation, and storage. And I can imagine the day when our friendly iron colleague working in a nearly sterile area hands over the best prepared and perfect sterilized endoscope, and we say to him, okay, Charlie, you made a good job today. Or should we come back to the discussion to disposable endoscopes in GI endoscopy? I think this could be more unpleasant than the ongoing discussion with the 5% risk. We have to handle with this risk, but I think we can the whole process more perfect in the future and to guarantee a more safe procedure in duodenoscope as in the past, because the problem is recognized and we're going on to make it better. Thank you very much for your kind attention.